If there were one aspect of healthcare delivery an organization could work on that would have the greatest impact on patient safety, it would be improving the effectiveness of communication on all levels, written, oral, and electronic. Critical thinking involves using a systematic approach to safe and quality care of the patient. SBAR is crucial in providing a pathway for nurses to think critically through a situation and to respond appropriately. Many situations of cardiac output require a quick intervention and the ability to think critically by the nurse. SBAR, Situation, Background, Assessment, and Recommendation, is an easy-to-remember, concrete mechanism useful for framing any problem, especially critical ones requiring a clinician's immediate attention and action. Critical thinking allows for an easy and yet focused way to set expectations for what will be communicated between members of the healthcare team, and it is essential for developing collaborative teamwork and in fostering a culture of patient safety. SBAR provides the link between critical thinking and patient safety, and Joint Commission has established national patient safety goals for hospitals. One of these goals is to improve staff communication by quickly getting important test results to the right staff person. Using critical thinking in SBAR will provide a systematic way to report clinical changes, test results, and other patient care issues to the care provider. This will ensure improved patient safety and improved care outcomes. Chapter 12, Nursing Assessment, Cardiovascular and Circulatory Function. Please remember to view the cardiovascular anatomy and physiology located in these previous slides, paying particular attention to the cardiovascular anatomy and physiology present in this slide, as it shows cranial circulation, pulmonary circulation, hepatic circulation, renal circulation, and their relationships between each other. Review the anatomy and physiology of the vascular system, including the arteries and arterioles, the capillaries, the venules and veins, and the circulatory needs of the tissues. Question: is the following statement true or false? Blood pressure in arteries is higher than blood pressure in veins. Answer: true. Venous return to the heart exists in a low-pressure system in which backflow is prevented by valves. Arteries and arterioles are higher pressure blood vessels. Remember the chambers of the heart. The right side, the left, is a low pressure chamber, and the left side is a high pressure chamber. The atrium are the upper chambers, the ventricles are the lower chambers. Heart valves consist of the AV valves, which are the atrial ventricular valves, and they have 2 and 3 leaflets. The tricuspid valve has 3 leaflets. The bicuspid valve, or the mitral valve, has 2 leaflets. The semilunar valves are half-moon valves, and they are the pulmonic and the aortic valve, respectively. The circulatory system of the heart consists of the coronary arteries. There are 2 main coronary arteries. The left coronary artery, which supplies the bundle of His in the left ventricle, and consists of the left anterior descending, which wraps around the left ventricle and is pretty much responsible for blood flow through the left ventricle. Lesions that approximate in the left anterior descending artery are often referred to as the widowmaker because of their propensity to cause huge problems in patients with MIs. The left circumflex wraps around the back of the heart and is the other main artery of the left coronary artery. The right coronary artery supplies the SA and the AB node and the right ventricle. If there are problems in the right coronary artery, oftentimes you'll see arrhythmias arise from the SA and the AV node, and particularly the right ventricle. The following slide is anatomy and physiology of the heart. Refer to the bottom of this slide where you see the muscular portion of the heart and its breakdown, the endocardium, the myocardium, and the epicardium, noting that the myocardium is a thick-walled muscle that surrounds the heart. And outside of the epicardium, you'll notice, is a pericardial space. This will become important later on when we start talking about things that cause cardiac tamponade. The coronary arteries, again, here's another picture of them, just shown in 3-dimensional. Again, we have another slide here that shows blood flow throughout the heart. Please review this. The cardiac conduction system. Remember that the heart actually has 2 conduction systems, One is the electrical conduction system, and the other is the mechanical conduction system. They work together in tandem to produce your heart rate, heartbeat, and cardiac output. The cardiac conduction system electrically consists of the SA node, which originates around the top of the right atrium. The SA node also has a small finger that leaps out into the left atrium, which supplies electricity to the left atrium in relationship to contraction. The SA node has some fingerlings that go down and they meet at the bottom, right, kind of where the right atrium is, into the septum, called the AV node. Most of your medications, or a lot of them, slow or change or alter conduction from the SA to the AV node, and that's important later on when we start talking about medications. Down into your intraventricular septum, you'll notice that bright blue leaf or area there. That is your bundle of His. Conduction abnormalities that originate in the bundle of His can cause lots of problems also. And then you'll notice that your bundle of His splits into the left and right bundle branch, and then back down into the Purkinje fibers, which innervate the whole bottom electrical system of your heart. The cardiac conduction system of the heart is composed of special tissue that's capable of forming rhythmic electrical impulses. The SA node is the primary pacemaker of the heart, and its inherent rate is about 60 to 100 beats per minute. The AV node synchronizes atrial and ventricular activity, allowing the ventricle to fill. If the SA node does fail, the AV node initiates an impulse, and its normal rate is about 40 to 60 beats per minute. Impulses are then transmitted from the bundle of His to the right and left bundle branch block and the Purkinje fibers. If the SA and the AV node fail, the ventricles can take over, but they contract at only of a rate of about 30 to 40 beats a minute. The electrophysiologic properties of the heart, there are 5 of them. Automasticity is the ability of all cardiac cells to initiate an impulse. Excitability is the ability of cells to respond to a stimulus by initiating an impulse, depolarization. Conductivity, cardiac cells can transmit the electrical impulse they receive. Contractility, the cells contract in response to an impulse. And repolarization, the rest period allowing myocardial cells to prepare for the next depolarization. Cardiac cycle. Diastole is the relaxation and filling of the atria. Systole is the contraction and emptying of the atria and the ventricles. Preload is the amount of myocardial fiber stretch at the end of diastole and just before contraction. And afterload is the pressure or resistance that the left ventricle has to overcome to eject blood through the semilunar valves and into the peripheral vascular system. Contractility is the force of cardiac contraction independent of preload. This next slide is very nice because it shows preload and afterload in a very simplistic fashion. Preload basically is the amount of volume that's coming into the ventricles at the end of diastole. And if you notice there, it looks like he's got a can of fluid and he's just dumping it into the heart. Things that increase preload are hypervolemia and regurg of the cardiac valves. So oftentimes when patients are in fluid overload, they'll get too much fluid coming back to the right side of the heart. It can't get pumped around and preload increases. Afterload is the resistance that the left ventricle must overcome to circulate blood out into the systemic circulation. And if you'll notice at the top of the little area where it says afterload, there's a little screw there. Anytime the aorta or any type of vascular resistance on the left side of the heart is higher, then it's going to make the left side of the heart work harder to overcome that ability to pump out into the systemic circulation. Afterload is increased in hypertension and vasoconstriction. Both of those cause a narrowing of the vasculature going out of the heart. Increased afterload equals increased cardiac workload. And some of our major medications that we treat patients with cardiac problems reduce preload and afterload, thereby reducing workload on the heart. Question. The student nurse is assessing a patient who has a dysrhythmia. The student understands that the electrical conduction of the heart usually originates in the SA node. What sequence completes this conduction? Answer, D. SA node to AV node to bundle of His to Purkinje fibers. This is the normal cardiac conduction route. Cardiac output. The electrical and mechanical properties of cardiac muscle determine the function of the cardiovascular system. Your heart rate refers to the number of times the ventricles contract each minute. Normal resting heart rate for an adult is 60 to 100 beats a minute. Stroke volume is the amount of blood ejected by the left ventricle during each systole. And cardiac output is the volume of blood in liters ejected by the heart each minute. This measurement is useful because it gives the nurse an idea of how well the body is being perfused by the heart. And you can measure cardiac output by using a pulmonary artery catheter, often known as a Swan-Ganz catheter. Normal cardiac output is 4 to 8 liters in a normal adult. Preload and afterload are two of the three interdependent factors that are important in assessing the heart. Assessment of the cardiovascular system. Cardiovascular health problems are associated with multiple complaints by the patient. Most often, these manifest as chest pain or symptoms of acute coronary syndrome, such as weakness, dyspnea, fatigue, palpitations, weight gain, syncope, extremity pain. An important thing to note is often that when women come in complaining of chest pain, their chest pain may not be the same as men. Women have a different pain pattern. Sometimes instead of having the classic radiating down the left arm, left-sided chest pain that most men have, women can have pain that radiates into the neck, up into the back, into the shoulders, and down into the right arm. So never just assume somebody with cardiothoracic pain is having some other problem because they aren't presenting with that typical left-sided chest pain radiating down the arm. Also remember that in your patients with diabetes, because they have a decreased ability to sense pain, they may come in not complaining of chest pain at all, and these are our patients that are our silent MIs. Assessment parameters. A thorough health history is completely important on these patients. Family history has been shown now to be one of the biggest indicators of heart disease in patients, so a family history is crucial. Please make sure you find out which medications your patient's on. It's vitally important if you need to give them other medications and to know their history. Ask questions about their nutrition and their metabolism, how well they eat, and those types of things. Elimination, activity. Activity is another thing that's been really, really important in the last few years. An article came out just a few months ago that talked about sitting being the new smoking, and most of us are sitting way more than we are moving. Cognition, sexuality, and coping are all other things you need to get a thorough history on so you can put it all together for your patient. Modifiable risk factors are things that patients can change, and so we ask about those often, such as smoking, physical inactivity, obesity, type A personality, diabetes mellitus, hyperlipidemia, and hypertension. And what are the current health problems, or what did they present to the ER with? In other words, what's their chest pain like? Did they have any dyspnea? Have they taken any medications at home for these things? Are they experiencing fatigue? Are they experiencing palpitations? Have they noticed any weight gain or loss recently? Do they notice that their feet are swelling? Are they dizzy? Are they having extremity pain of any kind? All of these things are important. Physical assessment. Make sure you're assessing their skin and palpating their skin. Check their blood pressure. The pulse pressure is the difference between the systolic and diastolic pressure. A normal pulse pressure is 30 to 40 millimeters of mercury. Pulse pressure can be an indirect measurement of cardiac output, so it is vitally important that we calculate that number. Also assess your patient for orthostatic changes. This can indicate any type of fluid abnormality. If your patient is laying and you check their blood pressure and they stand up and you check it again and it drops, they have some type of fluid abnormality going on. Arterial pulses, what's the rate, rhythm, and quality? Inspection of their jugular veins. Do they have jugular venous pulsations? Use the right internal jugular vein. And increased reading will be noted in central venous pressure, indicates right ventricular failure or fluid overload. Assess their lungs and abdomen. Are their lungs clear? Are you hearing rales? Do you hear bowel sounds in all 4 quadrants? Question. A patient's systolic pressure is 122 millimeters of mercury and diastolic pressure is 75 millimeters of mercury. What would this patient's pulse pressure be? The answer to this question is you want to subtract 75 from 122, and the answer is D, 47. A thorough heart inspection on these patients is vitally crucial, so we might want to make sure that we're inspecting their heart and also listening. Current literature does state that we listen to the patient's heart with the bell of stethoscope. However, whatever you can hear your client's heart sounds best with is how you should listen to them. Making sure that you're noting the areas of each specific area of the heart. So you want to start on top to the right-hand side of the sternum and listen to the aortic area. Then you move over to the sternoclavicular area, then over to the pulmonic area, moving on down to the tricuspid area, and over and off to the nipple line where the left ventricular or apical area is heard, and then also listen in the epigastric area to see if you're hearing any bowel sounds. On women with large breasts, you may need to lift the breasts and listen underneath of them, but it's vitally crucial that you listen to all areas of the heart, noting anything that could be abnormal. Normal heart sounds are S1 and S2, and they sound like lub-dub, lub-dub, lub-dub. If an S3 is present, that can be one of the earliest indicators of heart failure. An S3 will sound different. It will be in addition to S1 and S2. And oftentimes clinicians note that it sounds like the word Kentucky. So if you're listening to somebody's heart, you hear Kentucky, Kentucky, Kentucky. An S4, along with the other three heart sounds, can almost sound like a horse galloping and is referred to often as an S4 gallop. And in this case, it sounds like Tennessee. And you'll hear Tennessee, 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 Tennessee. Again, you're listening to the heart to see if you hear any snaps or clicks. Artificial valves will often click. Listening for any murmurs that sound like a whooshing sound through the valves, and also for a friction rub. And a friction rub will sound like sandpaper. This heart sound tutorial that's on here is very good to listen to because it has the actual sounds that you can hear. And I highly suggest you listen to it. Diagnostics. Cardiac biomarkers have made it very possible for us to really pinpoint oftentimes when patients are having their MI. And one of the most common ones that we use is CKMB. CK stands for creatinine kinase, MB stands for muscle band. Remembering that your myocardium is a muscle, and when it's damaged, it elicits an enzyme response that goes out into the bloodstream. So in CKMB, we'll see that initial enzyme climb at 3 to 8 hours. It peaks at 12 to 24, and it falls in 2 to 3 days. Myoglobin is another nice test because it's the earliest riser in all of our cardiac biomarkers. It rises in 2 to 3 hours, peaks at 6 to 9. But the disappointing thing about myoglobin is that it falls after 24 hours. So our patients that sit at home with chest pain, if we do a myoglobin on them, we might miss their cardiac enzyme elevation. Troponin T has been the gold standard for the last several years for enzyme cardiac biomarkers. Troponin T has an initial rise of 4 to 6 hours. It peaks at 10 to 24. And the nice thing about troponin T is it rises and falls after 10 to 14 days. This has allowed us to not miss many of our MIs in our patients like we used to in the old days. CKMB and troponin T are the gold standard for enzyme elevation lab tests. Another cardiac biomarker that's important is to do a cholesterol panel. Clinicians are getting away from doing total cholesterols because the number by itself really doesn't mean anything. If you do a total cholesterol, you need to also have the LDL, HDL, and triglycerides along with it. Always remembering that your LDL starts with L and it should be low. Your HDL starts with H and it should be high. If these numbers aren't, then that really indicates that there's something going on with your patient's cholesterol that may need addressing. Again, triglycerides too are a very good indicator of blood sugar control throughout a period and how well your patient's managing that. So that should be another thing that you do. Brain B-type natriuretic peptide, or BNP, is a test that's done to help us understand if our patients are having congestive heart failure. However, BNP can elevate in several different things. So one of the things that needs to be happening when you do a BNP is you also need to correlate clinical findings. In other words, am I seeing fluid overload signs in my patients, such as rales in their lungs, swelling in their feet, shortness of breath, and those types of things. PT, or prothrombin time for oral anticoagulants, has kind of gone off the mark now. The more new thing that we're doing is INR, or International Normalized Ratio. INR is the gold standard for understanding whether or not our patients on oral anticoagulants are within the acceptable limits for anticoagulation. The nice thing about INR is it's a standardized ratio that will be the same in a lab in the Midwest or a lab in London, England. So if I do an INR on my patient here, it'll be the same in London, England. The normal INR is 2 to 3. If you want your patient to be therapeutic on their oral anticoagulants, you want to have them more toward the 3 side and preferably over. PTT, or partial thromboplastin time, is specifically used in our patients who are on heparin. Patients that are on heparin will have this lab test so that we can understand if their heparin is therapeutic and we can adjust according to what we need to. ABGs, or arterial blood gases, determine tissue oxygenation. However, we often save these tests, arterial blood gases, until we determine whether or not our patients are going to need to have things that lyse clots, such as our clot busters. Serum electrolytes, sodium, potassium, calcium, and magnesium are also very important, as abnormalities in any of these electrolytes can cause cardiac dysrhythmias. And lastly, a CBC or complete blood count is another way to rule out some things and rule in some things. Oftentimes now, with our patients who have clotting in the coronary arteries, they have a clotting rupture, which is a massive inflammatory process. And because of this massive inflammatory process, the white count will elevate with an MI. If you're seeing a white count elevation in a patient, but their chest x-ray doesn't preclude anything such as pneumonia, you might be more specific toward an MI. And the other thing is a hemoglobin and hematocrit is important too in these patients, is because we want them to have an appropriate hemoglobin so they can carry oxygen appropriately. Other diagnostics that we use can be an electrocardiogram, a 12-lead EKG, so that we can look at all the layers of the heart and see what's going on electrically there. Also, the patient will be hooked to a continuous cardiac monitoring system of some sort. Chest x-ray determines heart size. Oftentimes, we'll be able to compare that previous chest x-ray to the one that they just had to see if there's any enlargement. If they've never had one before, we can look at the markers of the silhouette of the heart to determine whether or not we think the patient is having an enlarged heart. Angiography checks for vessel patency. So our patients who need an angiogram, they'll inject a dye and look for vessel patency within the coronary arteries. Cardiac catheterization can actually diagnose the blockage and the degree of blockage in our patient. So the angiogram checks to see if we have vessel patency, and if we don't, then cardiac catheterization is pursued so we can diagnose blockage. And oftentimes too, as long as when the patient is having a cardiac catheterization, they may also open up the artery with a balloon angioplasty and insert a stent. Electrophysiologic studies determine electrical abnormalities. So for our patients who are having reentrant tachycardias of some type, they can take them to the phys lab, induce the arrhythmia that they're having, and determine what is the best course of action to abate that rhythm. Oftentimes, it's electrical ablation in the phys lab. Exercise, electrocardiography, or stress test is the heart's ability to function during activity. Most people walk on a treadmill when this is happening. However, we do have some elderly patients or sometimes patients who just aren't able to walk on a treadmill for whatever reason. And in those clients, we can induce stress with medications and do the same type of thing. And then last but not least, our echocardiography. Our echocardiography or our echocardiogram gives ideas about the valvular structure and function and the heart's ability to eject blood into the systemic circulation. One of the important factors of electrocardiography is the ejection fraction. And we look at the ejection fraction because it tells us how well our patient's able to eject that blood out into the systemic circulation. Normally, ejection fraction in an adult patient is usually greater than 40. Anything between 20 and 40 is diagnostic of some cardiovascular problem, and anything around 20 is usually indicative of end-stage cardiomyopathy. Hemodynamic monitoring. Central venous pressure and pulmonary artery catheters, Swan-Ganz catheters, are a triple or quadruple lumen balloon-tipped catheter that's inserted by a physician via an external site. They're used in critical care areas to provide numerical information about blood volume, pump effectiveness, tissue perfusion, and fluid status. They require informed consent. And one thing to remember, when you have a Swan-Ganz catheter or a central venous catheter in place, make sure that you're looking for trends in your readings and not just one number. Central venous pressures. The catheter is positioned in the right atrium of the vena cava. It reflects right ventricular preload. Measurements come from a lumen that exits in the right atrium, and the normal venous pressure is 2 to 8 millimeters of mercury. Anything greater than 8, we consider hypervolemia or right-sided heart failure. Anything less than 2 is hypovolemia or reduced preload. And we'll talk more about this when we talk about medication. Pulmonary artery wedge pressures get the name from the wedging or the inflation of the balloon of the catheter in the pulmonary artery. The catheter itself is directed into the right atrium, and then the balloon is inflated, and then the end of the catheter floats to the right ventricle and out into the pulmonary artery. When the balloon is not inflated on the catheter, it sits in the right ventricle and gives us right ventricular pressures, which are very important. Measurements should be taken immediately, and then the balloon is deflated after the waveform is assessed and the measurement is gathered. Readings from the pulmonary artery wedge pressure reflect left ventricular preload. They reveal information about fluid volume status and function of the left ventricle. And the normal is 4 to 12 millimeters of mercury. Anything greater than 12 is fluid overload, left ventricular failure, or mitral regurg. Anything less than 4 is hypovolemia or afterload reduction. And sometimes afterload reduction can come from medications that we give, particularly nitroglycerin. I like this slide here because it shows our little man floating around on the pulmonary artery catheter, and he's pulling the balloon out as it's inflated. And this is a really nice picture because it kind of shows actually where that catheter sits. This is even a better slide, this next one, where it says PA catheter. It shows our PA proximal port, where it exits in the right atrium, and that's number 1. Number 2 is the port to the thermistor, that's number 2. And when you inflate that balloon, you're able to have that balloon float out into the system, and number 3 shows that port of the balloon where it's at. And number 4 is the distal port. And the distal port is designed so that it can sense temperature changes in blood flow out in there, and that's important when you're doing cardiac output readings. This next slide shows the waveform monitor when you have a pulmonary artery catheter in or a Swan-Ganz. When you normally have the catheter just sitting in the right ventricle, you get a really high tracing, like a really jagged, kind of high-looking tracing on that left side. When you inflate the balloon and float it out into the pulmonary artery, you occlude that artery, and then you get a dampening of that waveform. And if you notice on the right side how much flatter that waveform is, that's a good pulmonary artery wedge pressure tracing. When you see that dampening of that waveform, then you take your reading off your monitor. Once you get your reading, then you deflate your balloon and let it go back to where it was. That waveform just validates that your catheter is wedging in the artery where it belongs when you're trying to get that reading. Intra-arterial blood pressure monitoring. Another type of hemodynamic monitoring that's often done in critical care settings is that a 20-gauge IV catheter is inserted into the radial artery of the wrist and hooked to a pressure bag so that we're able to obtain continuous systolic, diastolic, and mean arterial pressure readings in blood samples. This is especially important when you have a patient on a ventilator and you're doing a lot of arterial blood gases. You're actually able to have a little stopcock there where you can draw arterial blood out of that, and that's very nice for your patient. And another thing that's often done is Doppler ultrasound studies, and those detect obstruction of blood flow to extremities or to the head due to thrombus or arteriosclerosis. And obstruction is no change in sound waves, and this may be used along with CT scans or analyzed to determine speed and direction of blood flow. Question: is the following statement true or false? Central venous pressure monitoring provides the care team with continuous systolic, diastolic, and mean arterial pressure readings. Answer: false. CVP is measured by positioning a catheter in the vena cava or the right atrium. It reflects right ventricular preload. Intra-arterial blood pressure monitoring or arterial lines are used to obtain continuous systolic, diastolic, and mean arterial pressure readings in blood samples. A nurse is orientating a newly licensed nurse on the care of a client who is receiving hemodynamic monitoring. Which of the following statements by the newly licensed nurse indicates the teaching was effective? D. A chest x-ray is obtained to confirm proper placement of the lines. Clients should be in the supine or Trendelenburg position. The transducer should be at the level of the fourth intercostal space, which is at the base of the right atrium. Air should always be purged from, not instilled into, the monitoring system. Question: a nurse is caring for a client who is receiving hemodynamic monitoring and has the following hemodynamic readings: pulmonary artery wedge pressure of 16 millimeters of mercury, central venous pressure of 12 millimeters of mercury. Which of the following is the client at risk for? Select all that apply. Answer: A, B, D, and E. Central venous pressure measures right ventricular preload, and elevated levels correlate with right-sided heart failure and fluid overload. Pulmonary artery pressure reflects left ventricular preload and reveals information about fluid volume status and function of the left ventricle. Elevated preloads clinically correlate with signs and symptoms such as crackles in the lungs, jugular venous distension, peripheral edema, and taut skin turgor. Question: a nurse is teaching a client the importance of remaining still following angiography. Which of the following is an appropriate statement by the nurse? Moving in bed raises your blood pressure. Too much activity increases your risk for infection. Moving in bed increases your risk of a complication due to anesthesia. Too much activity places you at risk for bleeding. Answer: following angiography or angiogram, is important that the client lie still due to the increased risk for bleeding at the insertion site. Newer types of fibrin plugs inserted into the insertion site have allowed patients now to lay flat for only an hour rather than the previous 6 hours that used to happen. Question: a nurse is reviewing a new prescription to administer 0.9% sodium chloride IV at 50 mL an hour to a client who's receiving hemodynamic monitoring and has an indwelling IV catheter in the left hand. Which of the following sites can be used for the administering this solution? Select all that apply. Answer: A and C. IV fluid administration can occur via a lock on a peripheral IV catheter, and then the proximal CVP lumen of a PA catheter is used for hemodynamic monitoring and can also be used for IV fluid administration. The thermistor port measures temperature differences between the right atrium and the pulmonary artery in order to determine cardiac output. The distal port measures pulmonary artery pressures but is not used for IV fluid administration.